Good evening, everyone. Welcome to the masterclass sessions. We at Yashoda bring about masterclass every alternate Tuesday, 7 to 8 p.m. So this week we are going to start with cardiogenic shock. So to moderate this session, we have seasoned examiners Dr. Yash Javeri, who is the director of critical care and emergency medicine at Regency Health Lucknow. It is a wonderful privilege for us to have you, sir. You are well known across the India. And we do have Dr. G.J. Himaldev, who is the head of the department critical care Apollo Hospitals at Sheshadripuram, Apollo Hospital, Sheshadripuram, Bangalore. And I'm fortunate to have him as a senior also. So, and who is a trained specialist from Australia and ECMO. Welcome, Dr. Himal. And the case presentation will be done by Dr. Karthik and Ram Prasad. Good to go, Karthik and Ram.
Thank you, sir.
Doctor.
A 65-year-old female presented with complaints of chest pain on and off for 3 days, sir, which is central in nature, heaviness, non-radiating, and relieved by antacids, and no variation with respiration, sir. But associated with breathlessness, which is progressive, comes under New York Heart Association classification 2 to 3, sir, grade, but not associated with palpitations or orthopnea or paroxysmal nocturnal dyspnea or syncope, cough, nausea, vomiting, fever, or negative history, sir.
Can you explain what is this NYHA classification?
Sorry, sir.
What is NYHA classification?
Sir, New York Heart Association classification for the dyspnea, sir.
Yeah.
Grade 4 grades are there. Grade 1 is like no dyspnea at a normal ordinary physical activity, sir. And second is like no symptoms. Second is like mild symptoms at ordinary physical activity, comfortable at rest. Grade 2 is like moderate symptoms, but they will be like experiencing symptoms even for an ordinary physical activity, sir. 4 is like breathlessness at rest.
And how do you differentiate between a cardiac dyspnea or pulmonary dyspnea? Not easy, but at times there are some telltale signs in this particular case, or otherwise, how will you differentiate?
Cardiac dyspnea can have orthopnea. PND is more typical of cardiac dyspnea, sir.
Yeah, and what else? This much of history, what else will you look at?
Patient might be having symptoms of bilateral lower extremity edemas will be there, sir.
Yeah.
And exertional dyspnea will be there, which is like cardiac in origin, sir. Pulmonary will be like at rest. Pulmonary may like the patient will be having associated fever will be there, cough with expectoration symptoms will be there.
Not necessarily, but orthopnea, PND could be suggestive of a cardiac, and the detailed history about features of persistent chronic heart failure, which are now going into a cardiogenic shock. Okay, we can proceed.
Patient is a known case of diabetes mellitus and hypertension, but medication status unknown. No other comorbidities, no similar complaints in the past, not on any other medications, no history of addictions. Patient attained menopause and housewife by profession. No significant family history regarding the cardiac issue, sir. Patient was taken to a nearby hospital with above mentioned complaints, where ECG revealed inferior wall myocardial infarction. She was provided with a loading dose of dual antiplatelets and statins were given and shifted here for further management, sir. On arrival to our ER, patient was conscious oriented, moderately built. She was afebrile. Pulse is within normal limits, 82 per minute, and BP is around 90-60, and room air saturation was around 95%, sir. Respiratory rate was mild and little increase, 22 per minute, sir. JVP is not visualized. No parasternal heave or tenderness. Systemic examination. CVS S1 S2 heard, sir. No murmurs. And in RS system, bilateral larynx is present. There were no added sounds. And abdomen was soft, no organomegaly and non-tender, sir.
What is the last slide? What is your impression? What is
Sir?
the clinical impression so far?
Sir, old age patient came with diabetes and hypertension, chest pain, on and off. Might be angina, sir. She might be experiencing angina. As patient is a known diabetes, there will be no classical symptoms of MI, sir.
But this patient had classical symptoms. They cannot be there. They could be deceptive, but this patient has typical angina. And now, patient had
Classical
ACS, ECG has revealed inferior wall MI. What else? What is your complete diagnosis?
Acute coronary syndrome.
Yeah.
We-
With is there shock?
No, sir. 90/60 was there, not less than that. On arrival, she doesn't have shock, and no clinical signs of hypoperfusion were also not there on arrival. So acute coronary syndrome, non-ST elevation MI was the initial diagnosis.
Okay. And patient is a known hypertensive patient, I believe, what I remember.
yes, a known hypertension.
So why are you telling no shock? There are no signs of end organ hypoperfusion.
No, sir. No.
But
At this
90
point, when she presented, there were no signs of end organ. Her sensorium was fine, urine output was good,
So
and
we have to especially if BP is just borderline, there is no obvious shock. We have to look for signs of hypoperfusion. And what are those signs? Just to refresh ourselves.
capillary refill time.
Yes, one.
We look at urine output,
Yes.
hourly urine output.
Yes.
Skin tiger, sir. Mottling
Skin
of
mottling,
any
yeah.
cold, clammy skins.
Yeah.
Altered mental status.
Yeah.
Enema, any edema is there, pedal edema.
That could be suggestive. Okay.
Then dyspnea grades, patient is like symptomatic at rest or like.
Okay. And we have to look at the clinical signs as well as the lab signs for shock like lactate and other parameters. Dr. Himal?
Yeah, so I think very important thing. So what are the lab parameters you would like to look at in this patient to look for the hypoperfusion?
Sir, we'll be looking at we'll do an ABG, sir, which reveals lactate levels more than 2 millimoles per liter, sir, which is a sign of hypoperfusion. And we'll be as patient is having chest pain, like we'll take a troponin test, sir, troponin value.
Regarding hypoperfusion, we can also do an RFT. Increased BUN and creatinine could be secondary to prerenal AKI.
Yeah, I think the lactate is right. Anything else? So you should be very specific. This RFTs and all at the later stage. So what else? If
Creatinine.
probably this patient
Creatinine.
has a central line, anything else you would like to know?
Urea.
Okay, that's okay. That's a part of RFT. What are the other signs? You said CRT and lactate. That's okay. So have you heard about central venous oxygen saturation and mixed venous oxygen saturation? Yeah.
Yes.
That is also very important in cardiogenic shock. So you need to know that. Suppose you don't have a central line, you can also look at what else can you do by doing a blood gas to look for the perfusion status, just like you. Anything related to carbon dioxide?
ETC.
No, there's something called as a VCO2 gap. Okay, so it's a difference between arterial and venous PCO2 levels. Okay, if it is more than 6 millimeter mercury, it indicates that the cardiac output is not good. So these things are very pertinent in a case of cardiogenic shock. And so you need to know these. This is a must when you go for an examination. And just before Dr. Yash sir takes over, so how do you define a cardiogenic shock? Because you said it is an acute inferior wall MI. And as sir rightly said, is a hypertensive patient, this BP is little low for that patient. So how do you define it? So you need to know this patient is in cardiogenic shock or not.
First you define shock, then you define cardiogenic shock.
Shock is critical end organ hypoperfusion. Secondary to any cause. Cardiogenic shock typically means end organ.
Numbers, put it in numbers.
So most trials have taken systolic blood pressure less than 90 mmHg for lasting for more than 30 minutes with clinical and biochemical evidence of hypoperfusion.
Okay. Now suppose this patient has been hypertensive. What should be the degree of fall of blood pressure?
More than 30% from their baseline.
For systolic. Okay. Remember that if the patient is chronic hypertensive, then 100 or 110 could also be shock, and this is a common clinical pitfall. Always remember this. And as Dr. Himal said, now how will you define cardiogenic shock?
Critical end organ hypoperfusion secondary to cardiac causes.
What is
Primary
something-
cardiac disorders.
What defines it? It does the what is the physiological dysfunction? What defines? What is
Sorry.
the cornerstone in the pathophysiology of cardiac shock?
Pump failures.
So reduced
Reduced stroke
Reduced
volume, reduced cardiac
cardiac
output.
reduced
Cardiac-
contractility is the main integral keystone in definition of cardiac shock. And what all can be the causes of cardiac shock now? In this particular case, what are your differentials?
Sir, acute myocardial infarction.
Topmost, yes.
And pericardial effusion, sir.
Unlikely because of the clinical symptoms. The topmost of diagnosis is almost certain. You don't have any provisional diagnosis in this particular case. Otherwise, it could be a chronic heart failure which is decompensating and decompensated because of ACS. This could be the other case scenario. Yeah. Dr. Himal, sorry.
Yeah, I think so. Just to add up to that, I think very rightly said. So you need to mention, and you mention as a the definition. So is an end organ perfusion with the lactate more than 2 or urine output less than 30 mils per hour, and altered mental status, and also cardiac index is better to tell not instead of cardiac output, because it gives you a better including body surface area. So it is less than 2.2. This comprises cardiogenic shock. So that's how you define it. And when you divide the causes of cardiogenic shock, better to divide it as ischemic and non-ischemic causes. So what you're discussing is ischemic, and there are a lot of non-ischemic causes of cardiogenic shock also. Why do we discuss about ischemic and non-ischemic, doctor? What matters in the long-term prognosis? Dr. Karthik.
Sir, ischemic, the early intervention, the ischemic failure can be like saved, sir. The mortality will be like less when we like early diagnosis and prompt treatment, sir, in case of ischemic heart diseases.
Which carries more, mortality compared? Which one has a more mortality? Is it ischemic or not?
Myocardial, ischemic, sir, ischemic. More than 70% trials say that more than 70% are involved in cardiogenic shock, sir, this myocardial infarction.
Yeah, so the 1 year mortality is also very high. It's nearly 60% compared to a non-ischemic myocardial infarction, which is around 36 to 40%. And what are the non-ischemic causes of cardiogenic shock? Just to complete the discussion.
Valvular
Ischemia
causes.
is, yeah. So list out all the causes fast.
Valvular causes like aortic stenosis, aortic regurgitation,
Yeah.
mitral regurgitation can have cardiogenic shock. Next, obstructive causes like cardiac tamponade, pulmonary thromboembolism can have shock.
Cardiac tamponade is primarily what type of shock?
Sir,
Cardiac tamponade, when we classify, what type of shock it comes into?
obstructive.
Yeah, classically it is an obstructive shock. Okay. Then other causes of cardiac shock? Cardiac causes of shock, cardiac shock.
Arrhythmias, sir, sustained ventricular tachycardia.
Yeah.
Electrical causes.
Cardiomyopathies.
Dilated cardiomyopathies.
And pregnancy related peripartum cardiomyopathy.
Excellent. Yeah.
Diabetic
also
cardiomyopathy can also progress to
coronary artery dissection, which is also more common in pregnancy.
And what is the commonest cause of non-ACS cause of cardiac shock in our ICUs, medical ICUs?
Sepsis, sir. Myocarditis.
Sepsis is a cardiac shock.
Cardiomyopathy.
Myocarditis, it could most of the time it is a viral myocarditis. Yeah, but it can happen with other diseases also, sepsis also. Okay.
Yes. And the commonest we see is probably drug-induced, toxin-induced.
Yeah.
Especially beta blocker and calcium channel blocker toxicity is one of the recent causes of cardiogenic shock. Yes, sir. Over to you.
Yes, please, Dr. Ram Prasad. Yeah, please proceed, sir.
At presentation, ECG showed Q waves in lead 2, 3, and AVF, which suggestive of inferior wall infarction. And we did a echo screening, and it revealed regional wall motion abnormality in anterior wall, anterolateral wall, and with severe LV dysfunction with EF of around 35%. There was a moderate mitral regurgitation and associated with the tricuspid regurgitation also there.
So one second. Back. So now you have a patient with ACS in cardiogenic shock, and added on you are finding MR, moderate MR and TR. How will this moderate MR and TR change your physiology and clinical picture? What will worsen physiologically?
So mitral regurgitation will precipitate the shock status, sir.
Yes. Both MR and TR will decrease, the forward flow will be
Stroke
decreased.
volume, sir.
Volume overload will happen, ventricular dilatation, and
Afterload will be increased.
worsening of heart failure. So this will further worsen the already pressed state of shock, and the coronary perfusion will also worsen because of moderate MRTR. So this will add on to the insult. Okay. So with moderate MRTR further worsens the prognosis now. Okay. And what could be the cause of moderate MRTR in this patient?
Sir, extensive myocardial infarction will lead to papillary muscle rupture, sir, which leads to new onset mitral regurgitation.
Yeah, that could be one cause, but that would be generally very severe and sudden. Ischemia, non-likely. Yeah. Next. Next slide, please. Next slide, please, Dr. Karthik.
30 minutes post-presentation, the patient's chest pain got worsened. Repeat ECG was taken, which showed new onset ST elevations in V3 to V6 leads. The ECG was shown below, which was taken.
Show us V3, one second, go back. V3 to V6 leads. Yeah, show us on the monitor, on the screen. Use this.
V2 to V6 are Andrew.
Yeah, V3 to V6, you can see ST elevation.
Sir, anterolateral.
Yeah. So, if a patient who is having acute coronary syndrome, inferior wall MI, and the chest pain is worsening, what is the differential and what does this tell you?
Sir,
Got the question? Already inferior wall MI was there, now the pain is worsening despite therapy. What do you think?
Could be worsening stenosis, causing
Worsening coronary stenosis? Yeah.
stenosis.
It could be right ventricular MI, otherwise for differentials of chest pain worsening. It could be extension of infarct. This patient does not have any bradyarrhythmia or complete heart block. If there is bradyarrhythmia or complete heart block,
Yes.
again the coronary perfusion will be hampered. Worsening of shock can also worsen chest pain. Reinfarction can be there, or whatever intervention, the drugs which you have used, it has not reperfused properly. So you have to go a step forward for reperfusion. Your medications have not worked nicely so far, so you have to go one step forward. What is the next step for you now? Yeah.
And we did a chest X-ray with suggestion of pulmonary edema, sir. Lung fields were plethoric and patient dyspnea worsened. So we just got a idea that patient started developing pulmonary edema, sir. New onset pulmonary edema. So this was an X-ray taken during that time. Lungs, there is no prominent bronchovascular markings, and lung fields were plethoric, which suggested pulmonary edema, sir.
Can I ask a question here? So how long does it take to do an X-ray? It takes quite some time longer, isn't it? So what is the alternative in a bedside if the patient becomes hypoxic at this state? What could have been done?
We can do
Auscultation.
focus, sir.
Don't say auscultation at this time. For your, super specialty degree, auscultation is not the right thing to be said. So focus, what do you want to look at focus in this patient?
Sir, B profiling, sir. We can see B profiling in bilateral lung fields. And IVC, like IVC will not be collapsing, sir. It will be like plethoric. And if there is any RV infraction, there will be like RV dilatation also will be there in focus finding, sir.
Yeah, so the B lines is there in the basal, but not in the apex. What does it mean? Suppose you do
Early pulmonary edema, sir.
early pulmonary.
There's nothing called early pulmonary edema. Suppose this patient has a adjacent consolidation or a effusion. So then probably you will not find a B lines in apical spaces, So if there is a flow rate coalescent B lines in all the areas of the lung, that's why you need to do a focus in all the fields. And that is more suggestive of a pulmonary edema. And simultaneously, this patient, especially with the changing ECG pattern, worsening shock and worsening pain, there can be a possibility of some disastrous complication which can cause severe hypotension in him, especially an extensive anterolateral MI. What is it?
MR.
Sir already said. Huh?
Papillary muscle rupture causing MR.
Yes, that's one. There's one more which we commonly see in our ICUs. And very, very, very disastrous. And acute intervention is required.
Ventricular wall rupture or free wall rupture.
Yeah, so either a ventricular septal rupture or a free wall rupture, which can cause a cardiac tamponade. Again, that can be determined with your point of care ultrasound. Yeah, so that's how the focus is more important than just X-ray here. Yes, sir.
Another cause, sorry, I forgot at that time. Very rare, but at times blunt trauma to chest can also lead to free wall rupture or papillary wall muscle rupture. We had a case some time back where the patient had a chest injury, blunt trauma chest, and after 2 to 3 days, patient had severe pulmonary edema and MR, and then we realized it is secondary to papillary rupture. Just remember, at times you can come across such case. So now we have this patient. Now, what is your complete diagnosis so far?
Acute coronary syndrome with pulmonary edema, sir.
With pulmonary edema, you are thinking
STEMI.
there is no shock here so far, no cardiogenic shock?
After this, she became breathless and then BP fell.
So acute pulmonary edema, type 1 respiratory failure, and cardiogenic shock. Okay. Always see, whenever you practice or discuss, give complete diagnosis from time to time. Whenever you have more data, in the files also, whenever you have more data, try to write full diagnosis. It will save you. Okay.
Okay, sir.
Yeah. Next, please.
Later, patient's BP dropped to 70 by 40 mmHg. Dyspnea got worsened. Patient was intubated in view of same and supported with mechanical ventilation. Patient was started on injection noradrenaline at 12 ml per hour, injection Lasix at 5 ml per hour, Nicorandil at 2 ml per hour, and injection heparin 5000 international units stat and tablet Brillianta, which is ticagrelor 180 mg stat was given, and patient was shifted to Cath lab for CAG with primary PTCA plan.
Just before we move on to this one question. So which is the first vasopressors you would like to start in a case of cardiogenic shock?
Norepinephrine.
So why is that? Because norepinephrine...
shock trials says that noradrenaline is like... a
lot of cardiologists still use dopamine. What trials? Some trials are very important for your regular practice. Why noradrenaline? I'll give you another options. So I have dopamine, dobutamine, noradrenaline, adrenaline. 4 options are there, which is next to you. Adrenaline. Why do you choose noradrenaline?
Adrenaline is arrhythmogenic, especially in patients with large infarcts. It can precipitate arrhythmias.
So this is your practice or is it based on any evidence? So whenever you say something, it's always should be backed up with your papers.
All vasopressors are arrhythmogenic.
Yeah. Why not dopamine? I would like to start dopamine. Do you want to start dopamine?
It has different actions at various concentrations in the blood.
Yeah.
So
which is the trial which said that dopamine use can be harmful if you use in these patients? Still, a lot of practice is there to start dopamine, but when you become an intensivist, you should know that why you should not use dopamine in these cases. Which trial is that? There's a SOAP2 trial by Deepak et al. Saying that when they compare dopamine with norepinephrine, so dopamine had a lot of arrhythmias, and that's when it was told it was not good. And again, epinephrine versus norepinephrine, which is better? You are right. You should be confident. You say noradrenaline, correct.
Norepinephrine.
Yeah. So epinephrine trial is also there, which suggested that a lot of meta-analysis and an RCT also saying that epinephrine causes more of lactic acidosis, more of tachycardia, more of arrhythmia. So the first primary choice in sepsis or in cardiogenic shock, it is norepinephrine. No matter whatever cardiologist says, that is your answer. Yeah. Yes, sir.
And if still the shock is persisting, what is your second choice? Even for cardiogenic shock.
dobutamine.
If it is a refractory shock, vasopressin should be added. Can you start dobutamine first line?
No, sir.
No.
No.
Why not?
Dobutamine is an inotropic agent with venodilator, sir. The risk of hypotension will be high. So whenever we are planning to start a dopamine, there should be like supportive vasopressor support, sir.
So first line should be always noradrenaline, and as Dr. Himal already told, it is much better than ADR, and the incidence of refractory shock is also less with noradrenaline compared to ADR. What else we generally do in refractory cardiogenic shock? What other drugs we use? Suppose there is a patient with beta blocker toxicity. What else can be used?
We can use milrinone or levosimendan, which have inotropic effect on the heart.
And what are the mechanism of action for
levosimendan is a calcium channel sensitizer. It increases the contractility, especially with the patients with decreased LV function.
Especially beta blocker calcium channel, at times they have very refractory shock, so you have to. And milrinone, what is the mechanism?
Phosphorus PDE3 inhibitor, sir. I know.
Sorry?
PDE3 inhibitor, sir.
Yeah. And there was a recent RCT for cardiac shock which did not show any improved cardiac outcomes with dobutamine versus milrinone in patients with cardiac shock. So you can use, but milrinone is costly. But some patients, especially beta blocker calcium channel toxicity, they will not respond to anything else. So before writing off any patient that, oh my God, we are already on huge doses, all in cardiac shock, always try milrinone or levosimendan. Other patients you can probably skip, but these patients, and also remember there is whatever literature says, there is no ceiling dose of all these vasopressors and inotropes. Books will say, but what ceiling dose is the dose when the side effects become overwhelming. That is the ceiling dose for most of us. Yeah. Otherwise, we have to fine titrate, especially acutely ill patients. Use the maximum dose which we can use. No defined maximum dose. Yeah. So don't write off patient that patient is already on 3 vasopressors full dose. You can increase the dose. And many of these acutely ill patients come out actually. Yeah. Next. Okay. Now this patient has cardiac shock, pulmonary edema, type 1 respiratory failure. What is the aim of your therapy? You have to do 3, 4, 5 things together. What are those things?
Inotropes.
Inotropes, one.
Increase the
First is what? We go back one slide. Yeah, no, this slide only. So we intubated this patient directly without an NIV trial. Why? Very important question.
Sir, patient is already hypotensive, sir. If we give NIV with more PIP, the chance of hypotension will be more high.
No, chances of hypotension are more with mechanical ventilation, not with NIV.
Yeah.
And NIV is actually grade 1 recommendation for cardiac pulmonary edema. However, this patient is already in severe shock and dyspnea. So whatever, right? If you think it is patient requires intubation, you can say the patient was in respiratory distress and patient required intubation. Very, very simple. Okay. Otherwise, if it would have been a little stable patient, NIV trial must be given for patient with cardiogenic pulmonary edema. Why?
Sir, NIV support will reduce the RA/RV load, sir. So preload will be reduced, so the work on
Okay.
myocardium will be reduced, sir.
Okay. What else?
And also helps with pulmonary edema, positive pressure.
Yeah. Dr. Himal, you want to add something here?
So very rightly pointed out. I think sir is very good in catching the thing. So see, positive pressure ventilation is always bad, but it is not on RARV. You know, it's mainly on the LV effect. So if the patient is in cardiogenic shock and there's initially NIV may not help, that's where you go for a positive pressure ventilation. So the positive pressure ventilation, if it helps in the cardiogenic shock, how does it help? The mechanism is not by reducing the RARV load. It's mainly by decreasing the transmural pressure, and the cardiac afterload is decreased. That's how the output gets better. And also by improving the oxygenation, it increases the myocardial oxygen supply and also end organ oxygenation. And also probably it'll help in diaphragmatic oxygen intake lesser. So overall, positive pressure ventilation will be useful for a cardiogenic patient rather than harmful practice. So better to use a mechanical ventilation. Maybe not in shock patients, try with NIV. But if the patient is in a severe shock, that's why your classification of cardiogenic shock is very, very important, which we probably we need to discuss before we move on to that. So if the patient is in a very severe hemodynamic instability shock, probably positive pressure ventilation is better. And it is mainly by decreasing that Laplace's law you need to know. And maybe you look into it later. So how does it reduce the wall stress and improve the cardiac output over the time? So positive pressure ventilation is one of the good modality for a cardiogenic shock. So can you elaborate the how do you define this cardiogenic shock, different stages? Sir, is it okay if they tell us?
Yes, we know. We have enough time. They told it's endless. We can go till 9 o'clock also. You have to go to gym. That is a different story.
Please tell, doctor.
So as per Sky
Excellent.
classification, we
Very
have
good. Yeah.
from A to E. A is at risk of cardiogenic shock. This is in patients which have acute large myocardial infarction with LV dysfunction. They are at risk of shock. B is beginning of shock. Here, patient doesn't have hypotension but may have a little bit of tachycardia, and this is a stage of impending shock. C is classical cardiogenic shock, where the BP is low and there is requirement of inotropic support to maintain the blood pressure. D is deteriorating. In this case, the shock is worsening despite fluid resuscitation and maximal doses of inotropic support. Whereas E is extremis, in which the patient is in cardiac arrest with ongoing CPR.
Refractory shock.
You're reading from the paper down, is it? Or
Sir?
yeah, so maybe when you go for exams, do not make it a habit that you know it by heart. That is important. Okay, so yeah, I think that's how you divide. Any other classification in the bedside?
Yeah, we have Forrester's classification.
Yeah.
Which is dry and sorry.
Since you're reading, I assume you know that. So at least to elaborate the heading. So that's about, depending upon LV or RV dysfunction, you classify it to 4 types. Any other classification? So one is Sky, the other one is wet or dry, those four columns. And the last one, there is something called as phenotypic classification. So it's called cardio-renal and cardiometabolic.
Cardiometabolic, cardio-renal.
These classifications you need to know. And just to not to miss the target, regarding the vasopressors, before we go to the next thing, Optima is the study which suggested that norepinephrine is better than epinephrine. And Doremi is the trial which suggested that there is no difference between milrinone and dobutamine. And there is another trial called Survive trial, which suggested, as Sir rightly pointed out, whenever there is a beta blocker, if there is a chronic beta blocker usage and that patient goes into a cardiogenic shock, you can't use your other inodilators. So there, levosimendan comes to your rescue. That's where you use your levosimendan. Otherwise, levosimendan versus dobutamine doesn't have a great benefit, and that was shown by your SURVIVE study. So these 4 studies you need to know: SOAP2, Optima, and Doremi, and SURVIVE. So this vasopressor knowledge is very important when you manage the cardiogenic shock. Yes, sir. That's all.
Okay, we were at what are the aims of therapy in this particular patient now? If there are 3-4 things which are going on physiologically, so what are the aims of therapy now?
Sorry, sir.
So what is the aim of your therapy?
Aim of therapy
Aim of therapy, yeah. In this
to
particular
restore
patient.
perfusion, to restore peripheral perfusion,
One.
and
To combat, to resuscitate shock status, and to relieve the symptoms of pulmonary edema.
and restore perfusion to the heart also.
Okay. So first is
Primary
oxygenation,
perfusion.
NIV or intubation, whatever is required. Second is optimize blood pressure with vasopressors, inotropes, whatever is required. Third is optimize contractility. Okay. And fourth is optimization of volume status. Despite it is a cardiac shock, still the patient could be underfilled or overfilled. You have to look at the ultrasound again. Go back to ultrasound again, look at the volume status, IVC, and whatever tools you want to use, and decide on volume status. Okay. So these are the 4 main pillars of your treatment for a patient with acute coronary syndrome and pulmonary edema. Remember this, because if you miss one, it will be a disaster. You cannot miss any one of these. And reperfusion strategy is most important. Yeah. Next, please.
Diagnosis: acute coronary syndrome, anterolateral ST segment elevated myocardial infarction with cardiogenic shock, CLIP class 4 with pulmonary edema.
What is CLIPS classification?
Sir, there are like CLIP four type of classifications are there. Depends on the shock status, sir. Mild, moderate, and severe. The last is like a cardiogenic shock with pulmonary edema, sir, class 4.
First is mild, or it is no clinical signs of heart failure, CLIPS. First is no clinical signs.
No, first is no
Second,
clinical
yeah.
signs, sir. Second is crepitations, but less than
Only lower
lower
lung
half.
fields, sir.
Third is crepitations all over. Fourth is
Acute pulmonary edema.
cardiogenic
Frank
shock.
pulmonary edema.
So remember these clinical, because this is an easy score to do. Remember such scores, and always look at the JVP also. Do not forget JVP. Okay. Yeah.
Patient is planned for coronary angiogram with primary PTCA, sir. In Cath lab, the findings were triple vessel disease, which involved proximal LAD of critical stenosis of 99%, mid LAD of 70%, and ramus with ostial 70% stenosis. So it was diagnosed as coronary artery disease with triple vessel disease. So plan is the primary PTCA done with drug-eluting stent to lift anterior descending artery, sir.
Okay.
In the cath lab, patient had a persistent hypotension and bradycardia with intermittent 2:1 AV block with worsening vasopressor requirement and temporary pacemaker implantation done, sir. IABP was placed with 1:1 augmentation and shifted back to ICU. The patient was shifted back to ICU.
How does IEBP works?
It works on counter pulsation principle, sir.
Yeah.
During diastole, it inflates, and during systole, it deflates.
The
Thereby
principal word is diastolic augmentation, sir. It uses a helium gas during diastole. It inflates and it pushes the blood to the proximal aorta for the better perfusion of myocardium, sir. During systole, it deflates and it reduces the aortic afterload, sir.
Okay. Now this particular patient, will you choose IABP or will you choose an ECMO, and why?
Sir, shock 2 trial determines IABP versus Optimus medical therapy. They told like no mortality difference over 30 days, 90 days, or 120 days, sir.
Yeah. So IABP probably if it was a refractory shock, your shock is still not improving with your intervention and reperfusion, then
Pardon, sir. Pardon.
if your shock was still refractory,
Yeah,
despite
sir.
IABP it is not improving, then will you like to go for
Then
BA
end
ECMO
is
or not?
ECMO, sir.
Yeah, then you like to.
BA ECMO.
Okay, Dr. Heman, you want to add something? Your field of interest.
So, Karthik and Ramprasad, before you jump to the, all these hi-fi mechanical circulatory device, do you want to monitor this patient and optimize your vasopressors and try to get things better so that it doesn't go into that stage? So, how would you like to monitor? He's come to ICU now, and his output is just tailing down.
Sir, I will going with basics pulse rate, arterial BP monitoring, sir, and CBP monitoring, and we can opt for pulmonary artery catheter monitoring, sir, which was already done in Cath lab. So pulmonary artery catheter, pulmonary capillary wedge pressure will determine we can get mixed venous saturation, sir, which is normal is 50 to 70%. It will be less in cardiogenic shock, sir. So cardiac output can be determined, cardiac index can be determined, stroke volume can be determined from the pulmonary artery catheter, sir, parameters.
What
So
else? What are the other? See, PA catheter. First one is what is the evidence of putting a PA catheter in these patients? Okay. And what does the evidence suggest? That can we go ahead and put, or is it useful? Second one, what are the parameters you're going to get from PA catheter? And third one is based on the PA catheter, how do you titrate your treatment? These three things you should discuss now. First is what is the evidence for PA catheter, pulmonary artery catheter?
So recent recommendations doesn't doesn't tell the routine routine use of PA catheter, sir.
Which recent recommendation? So the old trial was a Pacman trial. Okay, so that one was the one which was discouraging not to use PA catheter because there was not much of a benefit from using a PA catheter. But there are a lot of recent literature suggesting that usage of this PA catheter in cardiogenic shock has been very helpful, and it is more of positive evidence. So you need to put a PA catheter for a bad cardiogenic patient. It is going to be, especially SCAI classification, D and E is definitely going to be helpful. So you put a PA catheter. What are the parameters you said listed out? What do you get?
Sir, RA pressure, pulmonary capillary wedge pressure, mixed venous saturation, and we can get a stroke volume, cardiac output, cardiac index simultaneously. We can get these parameters can be obtained from PA catheter, sir.
Okay, and something else which is very relevant. With this, you can titrate your inodilators or a vasopressor. What happens in a cardiogenic shock? What happens to the systemic vascular resistance?
It will increase, sir.
Yeah, so you will get a SVR and SVRI also along with that PA catheter monitor. So that helps you to titrate your dobutamine or a norepinephrine. If SVR is very low, then you have to go for a higher dose of norepinephrine. If the SVR is very high, then probably you have to go for dobutamine to reduce the afterload. That's how we do it and titrate it. And nowadays in PA catheter, have you heard about a cardiac output and pulmonary vascular permeability index?
Yes,
so that is the one which needs to be discussed because that is what is coming up and you need to discuss about it. Cardiac power output and PVPI. Okay. Do you know anything about it? So
cardiac power output, mean arterial pressure.
Very good. Yeah.
Mean arterial pressure, and we'll be calculating systolic blood pressure by 451. There is a formula, sir.
Minus RAP by 451. And if the cardiac power output is less than 0.6, that indicates cardiac contractility is not very good. You need to optimize it by using your inodilators like dobutamine or milrinone. Similarly, PVPI, this is for your LV dysfunction. That's why I told you differentiating between LV and RV is very, very important. So if you want to target the RV dysfunction, again, PA catheter will be helpful because you can get something called as PVPI, that is systolic minus diastolic, okay, divided by RA pressures. So that one will just you how severe the RV dysfunction is, and you can titrate your pulmonary vasodilators based on that. So nowadays people are targeting that rather than plain PCWP or CVP or just a plain cardiac output or a map. Okay, this is how you go advanced over the time by using invasive cardiac output monitoring device. Other than PA catheter, do you have any other devices which is used, which you are being using in your thing, which can guide you, which may not be so invasive like a PA catheter, which can get you cardiac output, cardiac index, SVR, even your pico, litco, sometimes even flow track. Have you heard about flow track?
Yes, sir.
So those things also can guide you how do you manage this case. So by doing this, if you can manage your vasopressor support, you can probably avoid them going into mechanical circulatory device. So now coming to sir's question, when do you decide on IABP or an ECMO? What is the problem with ECMO?
Sir, it's
I think it's
Increase the afterload.
very good.
Increases
So if given a choice, I would definitely avoid an ECMO for a patient because it increases afterload. So is there any other mechanical circulatory device which can counteract this problem of ECMO?
sir, ventricular assist device, impulna, sir.
Yes. So
It works independent of the heart rate, sir.
yes.
And what is getting more and more famous now? Impella and other one is what?
Tandem heart rate.
You have a mechanical circulatory unit at your hospital? And yeah. Okay,
That
you
is
must be
asking, do you
familiar
have
with,
the
you must be familiar. If not at your center, other Yashoda centers obviously are having, so you must visit them if it is not at your center. And cardiogenic shock, because some centers see a very less number of cardiogenic shock, so go and get familiar with PA catheter. At times you will require it, and when you require, you have to put it. So be familiar with PA and IABP also. Okay, you have to see some cases. Other shock management is almost similar and streamlined, but cardiogenic shock you have to think on mechanical assistance devices also.
You can proceed with the next slide. I think what sir said is right. So I think we will discuss about ECMO later on. Let us see what happened.
Patient got shifted from cath lab to ICU. Mechanical ventilation support continued. And the vitals were obtained at arrival in ICU. Pulse rate was around 120 per minute. BP was 100/60 with injection noradrenaline at 15 ml per hour. Yes, saturation was 98% with FiO2, 70% with PRVC mode. Temperature found to be normal, and urine output was around 50 ml per hour. In the ICU, ECG showed wide QRS complex, so which we started the patient on injection loxicod at 6 ml per hour. So the infusions which we used, noradrenaline was used, fentanyl atracurium was used, injection tyrofenone at 8 ml per hour. Patient is a known diabetic, and like we found dysglycemia was there, so we started on injection Newman atropine insulin at 10 ml per hour, and injection Lasix at 5 ml per hour, and injection nicorandil we continued at 2 ml per hour. Sir.
I will just one second. You go back. Always write the doses in milligram or microgram. Never use ml.
Okay, sir.
Never. Okay, and if you use ml in the bracket, it should be mentioned what each ml contains. Always. ML business can land you in trouble at times. So never use this ML. So now, why are you using atracurium in this particular patient? Yeah. Why was it required? Why is muscle relaxation required in this particular patient?
She is
Sir,
Sorry?
elective mechanical ventilation purpose, sir.
Most of the electromechanical ventilation can be done with some sedation. At times you require muscle relaxant, yes, but not all patients require muscle relaxation for mechanical ventilation. And the problem, what is the problem with atracurium? A peculiar problem, which can worsen your shock because it's a very delicate patient. It can lead to histamine release and it can further worsen the shock. So be very, very careful. Although it's a short-acting drug, and if there is some renal dysfunction, hepatic dysfunction, it is better. And now cisatracurium is also available in such cases if you want to use. Why you wanted to use Lasix at this point? At one end you are using warheadin, which is quite high dose. So see, if MAP is less than 65, 70, urine output will not come or whatever you give. And Lasix is also a dilator, vasodilator. So be careful with such combinations, especially if it is a borderline shock, you can still go ahead. But if it is such a refractory shock, be very, very careful with each and every drug. Okay. Yeah. Next. Dr. Himal, anything to add here?
Sir, I think my question was also why did you start at trachurium?
So not all patients require muscle relaxants.
Yes.
Unless it is a difficult ventilation.
Correct.
Or initial phase of ARDS, those patients only require. Rarely the sedation requirements are huge. You are not able to control the patient. Patient is pulling out despite. At that time, it could be a time buying strategy. Give a shot, which again has to be avoided. Okay.
Completely agreed, sir. So only one other condition where I would use paralyze him completely first 24 hours. Not all the patients, excellently put out by sir. But you use loxicod for this patient, no? Lignocaine. For what? So this is one of the cause for cardiogenic shock with refractory shock. So you get a lot of arrhythmias. It's called storm, VT storm, or was electrical storm. So if there is an electrical storm, which is the primary drug of choice, the same patient develops a VT, and do you know when do you call it as a VT storm? There is a definition for that.
We have sustained VT and non-sustained VT. Sustained is more than 3 broad complex, 3 VPCs lasting for more than 3 consecutive VPCs, and it is lasting for more than 30 seconds. Sustained.
Yeah. So in 3 episodes in 24 hours, it tells you a VT storm. Okay, so if there is a VT storm, no more, there's an ischemic VT storm. So what is the primary drug of therapy? Do you give lignocaine, loxicod, or do you give something else?
Amiodarone.
So amiodarone is the first drug of choice for any VT storm. Then, in spite of the best of amiodarone, you give 300 milligram bolus. Then after you give 150 mg. After that also VT is not getting converted. Then you start your lignocaine. Or suppose the patient has a long QT syndrome where you can't give amiodarone. That's when you start your loxicod infusions. So in these patients, no matter how much ever you give loxicod, amiodarone, shocks, continuous shocks, the things won't settle down. So there, the only thing is to sedate them very well, paralyze them. That's the only indication, as wonderfully put out by Dr. Yes, sir. There is no other indication for paralytic agent other than this. And if there is a VT storm, anything else can be done for this patient other than lignocaine? Have you faced a VT storm? You will know if you faced a VT storm, what is a VT storm. What can be done? You have used lignocaine, you have given continuous, you place the pads on the chest and give continuous cardioversions or defibrillations, whenever required. Generally, it will be a cardioversion.
Cardiac reconstruction therapy.
No, not in this situation. Something in lines you can do a radiofrequency ablation, ablation of the VTs, or alternatively, there are practices of giving a stellate ganglion block or sympathectomy, cervical sympathectomy. These are the therapies which are tried. And when nothing works out, that's when you go and dump them or put them on ECMO. ECMO can be a salvage measure there. Since you bought out loxicod, I thought I'll put it across, sir. That's all.
Very nice points.
Yes, sir.
Next, please, Dr. Karthik.
Investigations, like we have boxed the investigation from day 1 to day 4, sir. TLC has been increased from 15,000 to 23,000, and it stepped down from 18 to 17,000 at the last end of the 4th day. And creatinine started increasing from 0.9 to 1.4, and it increased to 1.5, which is non-oliguric. On day 4, it started reducing, sir, 1.4. Potassium electrolytes was within the normal limits over the course of the period. As the patient is a known diabetic, patient had a HbA1 uncontrolled HbA1c, which is at 7.6, and thyroid screen was found to be normal, and complete urine examination was found to be normal, and After 2 days of mechanical ventilation, the X-ray was found to be better than the admission X-ray, sir. And LFT were mildly increased. Liver function tests were mildly increased, sir. So these are our investigations
There is
parameters.
no value of doing a daily TLC, and don't even look at TLC. Okay, any stress will increase TLC, so don't look at TLC at all. Other important thing with creatinine rose, which was obvious because there was volume disturbance. It is very difficult to be very precise with volume. SGOT, SGPT, because there was ischemic hepatitis and many drugs which are hepatotoxic were being used, so it's okay. That's okay. Yeah. Next.
Day 2 at ICU.
What were the causes of raised creatinine in this particular patient? What other causes?
Sir,
Contrast induced
Yeah,
and
minus
hypoperfusion.
contrast and shock.
shock status.
Hypoperfusion, yeah. Okay.
Day 2 at ICU. Patient starts shock status improved and sensorium started improving. Patient got extubated and NIV support given. AKI suspected in view of increasing creatinine. Injection Lasix infusion was stopped. IABP was continued on this day 2 and temporary pacemaker was removed, sir. And day 3 and day 4, the hemodynamics improved. Shock was improved. Vasopressor was weaned off and IABP removed. O2 support continued with the low flow oxygen devices. AKI started resolving with decreasing creatinine levels and adequate urine output. Dysglycemia control. ECG rate and rhythm control achieved. No complications observed with IABP management and patient planned for discharge, sir.
Nicely managed. Don't write AKI suspected. It was AKI. Yeah. So it's your terms, whatever terms you use has to be very, very precise. It should be concise and precise in your notes also. So when will you like to wean off a patient on IABP? And how will you wean off a patient on IABP?
We change the augmentation rate. We change it to 1:2 and then 1:3. If he is stable, BP is stable on 1:3 for more than an hour, then we can try to wean off IABP.
Anything else to add, Dr. Himal?
So this patient, you have made it easier. So suppose this patient has gone into worsening acute kidney injury. What are the possible other reasons? Sir said, I think he has already told. Can your IABP cause AKI?
Yes, sir.
If
So where do you place the IABP?
it should
position?
be between the left subclavian vein and the renal left subclavian artery and the renal arteries. If it slips downward, the renal perfusion will be affected, causing worsening AKI.
And when the patient is on IABP, what are the things you do look after? The monitoring part.
We can do X-ray. Based on X-ray, we can check the position. It is supposed to be above the left main bronchus between second and third intercostal space. Then we can also do a transesophageal echo to check the position of IABP. And also fluoroscopy we can do.
What do you monitor when the patient is on IABP?
Peripheral pulses, sir.
Yeah. So the digital pulsations. And how do you maintain them whenever there is an external thing in the artery? Do you give anticoagulation?
Sir, no, sir. In IABP, we don't use anticoagulation, sir.
Why is it?
Sir, risk of bleeding and
So some centers do practice anticoagulation because anything in the artery requires some sort of anticoagulation. Because these patients are already on antiplatelets and there is a chance of bleeding. So there is actually conflict of interest whether to start or not. But if you have a good monitoring system and the risk factor is not so much, then probably you can use anticoagulation as a part of entire therapy. Arrhythmias, multiple lines in the patient, but monitoring is very, very important. So this patient goes into acute kidney injury, hemodynamically unstable, severe LV dysfunction. How do you decide on dialysis? Output comes down, acidosis is building in. What modality of dialysis technique you want to use in this patient?
CRRT.
we'll go with continuous renal replacement therapy. Most probably slow efficient dialysis, sir, which is patient is in shock state.
So when do you decide to go on a dialysis? Whether you want to start them on early dialysis or you want to wait what would be your indication to start dialysis in this patient?
Persistent metabolic disturbance, high lactate level despite fluid resuscitation and shock treatment, and refractive shock state and refractive hyperkalemia, and anuria, sir, anuria for more than 12 hours. So we'll decide based on that, sir. We'll decide based on that. Renal replacement therapy will be decided based on those factors, sir.
Yeah. So there's no role for an early renal replacement therapy. It should be a routine indication how you do for any other renal replacement therapy. So there is no, evidence is also there is no point in jumping and doing an early. Another thing with your CRRT would be beneficial in this patient is you can also target some ultrafiltrate removal once the patient is stabilized. So that is very important to reduce the stress on the heart so that your weaning becomes more better. So RRT is the choice of therapy. Yeah.
High lactates despite resuscitation are not an indication for any renal replacement therapy.
Yeah.
Unless it is something like hyperlactatemia, which is because of metformin or other drug induced. Otherwise, lactate per se is not in. But metabolic acidosis, refractory metabolic acidosis, is an indication for renal replacement therapy. The simplest and commonest indication which you should remember, if you think your patient is requiring soda bicarb for acidosis, it is the time for renal replacement therapy. Very, very simple. Do not forget this. If the patient requires soda bicarb, not a single dose, again and again, and patient has AKI, the time for CRRT for renal replacement therapy has come. Another common reason which we missed in the discussion was Lasix. Lasix is also nephrotoxic, especially high doses in a patient with diabetes, hypertension, chronic heart failure. 3 days, more than 3 days of Lasix can be cause AKI. Otherwise, also Lasix is a nephrotoxic drug. So you have to be very, very judicious in using Lasix when and when not. One of the most abused drugs in our ICU. Okay, there are some questions and there are some comments. I'll read out. Dr. Niranjan responded to a question about mechanical complications, flow track and Vigilio. So as Dr. Himal pointed out, PA catheter and invasive because the usage is fading away except for the cardiac center, but still we all as critical care practitioners should be familiar, if not at least some device arterial lines which give you the cardiac output parameters and stroke volume SVR. You should be familiar. It could be flow track, VGD or whatever device. And there are some thoracic impedance devices which are very, very vague and imprecise devices, but something is better than nothing. And there is another question, Ambedron for hepatotoxicity. Dr. Rushe has asked, sir, will contrast-induced nephropathy will be evident on day 2? Dr. Himal.
Yeah, so nowadays contrast-induced nephropathy is being questioned. So whether really contrast causes the nephropathy. So if the diagnosis is required, then be bold and go ahead with contrast. The contrast doesn't cause a kidney injury per se unless you're severely volume depleted. So in a sepsis or a severe volume depletion state, in a case of traumatic hemorrhagic shock, there if you give contrast, it can cause some problem to the kidney, but not in a case of cardiogenic shock where there is volume overloaded and already there's so much of volume that should not cause any contrast-induced kidney injury. And the contrast per se causes problems by drawing the fluid into the lungs, so it causes more of pulmonary edema. That's the reason we dialyze somebody post contrast, not because of contrast-induced kidney injury per se. So yeah, so don't worry too much about contrast-induced kidney injury now.
So if your patient requires contrast, you have to go for contrast, and the diagnosis is most important. Other thing is use the smallest dose of contrast, because most of the time these technicians in the radiology are giving contrast. So if the patient is at high risk of AKI, talk to your radiologist. They give the minimum dose. They finish the study very, very fast. They should not repeat the contrast for whatever reason. And you have to have this nephrotoxic stewardship in your ICU. What is nephrotoxic stewardship? Try to avoid using drugs which are nephrotoxic, U volume as desirable, and drugs like Lasix, acyclovir, and other agents, amikacin and all, have to be avoided. So you have to have overall stewardship also. Next question is from Dr. Omar. SCVO2 is already discussed. Lactate, high lactate levels are indicators of shock. Perfusion markers. If lactate clearance remains poor, that is a very, very poor sign. And lactate levels correlate with mortality. Higher the lactate, more is the mortality. Very, very simple. When do we think for cardiac transplants? A very good question. I'll put this question to our presenter, Dr. Ram Prasad. In any patient with cardiogenic shock, always have a multidisciplinary approach. Always involve your cardiologist. And if it is refractory and the diagnosis is uncertain and patient is not improving, involve your cardiac surgeon also. So this particular patient or any patient with ACS, when will you think about cardiac transplant?
In stage D heart failure sky classification, we think about cardiac transplantation when they are not
Sorry?
in stage D of sky classification. Patients in stage D, there's an indication for cardiac transplantation. Then that is the stage we start them on mechanical circulatory devices as a bridge to transplant.
And some other chronic cardiac conditions like cardiomyopathies and various other indications for cardiac transplant. That is a discussion separate. Dr. Santosh, what dose of fentanyl will be recommended in shock patients on ventilator? I'll put it to Dr. Karthik.
Sir, sorry, sir.
What will be the dose of fentanyl you will start a patient in shock on ventilator?
What dose of
Dose of fentanyl.
Fentanyl. What
Yeah.
dose?
Sir, fentanyl like 1 to 2 mics per kg, sir.
Yeah. Generally, it is 1 to 2 mics per kg. Lesser is better. But if the patient does not do well with 2, we often go to 3 or rarely higher doses also. Generally, 1 to 2 microgram per kilogram is the acceptable dose. If we require very, very high dose, if suppose 3 mics per kilogram also the patient, you should add another drug. And generally, propofol or midazolam is added with fentanyl. Do not use fentanyl alone. Why, Dr. Karthik?
Sir, fentanyl is like excreted by kidney, sir. So there will be like more chances for kidney injury also.
No. Fentanyl is not nephrotoxic.
Fentanyl will cause hypotension, sir, and apnea.
Yeah, high doses it can cause. No, but why should we combine it with say drugs like midazolam and
sir?
Anesthesia? Who is anesthesia?
Synergistic effect, sir, so that the
what else?
doses will be low, sir.
Sorry?
Sir, it's called synergistic effect, sir. So the doses which we require, it will be like requirement will be low, sir.
Okay. Who is anesthetist by background in both of you? Karthik.
Sir.
Yeah, you should answer this in detail. Yeah. What will midazolam do or propofol do?
Sir, midazolam, it's a benzodiazepine class, sir.
Yeah.
It will cause bradycardia, sir. Bradycardia, hypotension.
No. What is the basic mechanism? What type of drug it is?
Sir, benzodiazepine, sir, GABA agonist, sir.
What form we use it in anesthesia practice?
So sedation.
Yeah. Sedation and amnesia. See, many patients, especially on ventilator, they have this post-traumatic stress disorder because of the flashbacks from ICU. And the most painful procedure in the ICU, if you do an audit, is then arterial puncture. So remember that some of the things could be painful, especially the position lying in bed for so many days is itself painful. So you have to give analgesia as well as sedation combined. So use a combination.
Okay.
So, any more questions? Dr. Himal, your comments, then I'll summarize.
Yes, sir. So, Karthik Ramprasad, it is Sky classification E, we go for cardiac transplant or mechanical circulatory device. D still has some, you still have some time to bridge it. So, one question is like, finally, we'll end up with ECMO because ECMO is my favorite topic, so we should not, ECMO, you are worried about ECMO, but you can't put your IBP, Impella for all the patients. When the patient is in a severe RV and LV dysfunction and patient is very sick in the bedside, the first thing to go is a VA ECMO, okay? So, because you need time to do all these Impella and, your LVAD and all that stuff, even tandem heart and all those things, you need to ship them to a cath lab. So if at all ECMO is used in this patient, you are worried about what afterload? What are the ways to curtail the afterload in these ECMO patients? Now you put on ECMO. ECMO is put most of the cardiogenic shock patients in most of the centers because everybody Impella, the problem is cost. No, it's not available extensively. ECMO is what is being done, but there are things to help salvage the ECMO thing also. How do you reduce the afterload, or how do you decompress the left ventricle? Because ECMO increases the load on the left ventricle. What are the ways to decompress the left ventricle?
Sir,
You all
single cannula VA, single cannula concept VA ECMO, sir.
no. You have to reduce the LV thing. Already you discussed one already. IBP again is one of the decompression strategy. Okay. Along with ECMO, they put IBP. Along with ECMO, sometimes Impella can be put. There is something called as LV venting. You need to read about it. They put a hole in the LV and drain the blood out so that LV doesn't get distended. So LV venting is one of the way to reduce the afterload. So ECMO is very useful. There are many studies which says that ECMO is still in a gray zone, but in a cardiogenic shock with a refractory cardiogenic failure as a bridge, I think Dr. Yasser rightly said, whenever you plan something, when you put somebody on a IABP or a mechanical circulatory devices, it is always a bridge. It's a bridge to therapy that you wait for the heart to recover, or it's a bridge to recovery. No, that's what I said, and bridge to transplant in the end. Heart transplant. If the heart transplant is not available, it can be a bridge to a bridge. In the sense, it can be a bridge to LVAD or a Impella. That's how you do it. It should be a bridge. So it help you tide over the crisis and get the ultimate result. So that's how we use ECMO in our practice and sustain things. Yeah.
Any other question? Okay, that brings us to end. Dr. Ravi Shankar, your expert comments, then we can probably end this.
Yeah, thank you, sir. That was a wonderful discussion, actually. I think probably a couple of things what I would like to stress upon was, whenever there is an inferior MI, probably you have to look for RVMI also. That is one thing probably which we didn't discuss, actually. The second thing is, the role of fluids and NTG in these cases, actually, because initially we suspected inferior wall MI. So generally, if there is an RVMI, that is, cardiac output is dependent, RV output is dependent on the fluid. So that concept still holds good. And the last part is, I was surprised that the patient had a, bradycardia with the TVD, and we didn't do much for the RCA, and the patient improved. That is a bit surprising for me without intervening the RCA. The last, I think, what Himal was pointing out was, the combination of Impella and which we call as ECPella, actually, ECMO with Impella. So a combination to, do LV venting, actually. So these are the couple of things probably, I just want to, stress upon. But I think that was a wonderful discussion. Yes, sir, bringing about his expertise over the years, and, Himal, adding on with the ECMO component, actually. And I think Karthik and Ramprasad, they have done quite well, actually. So probably I think because you are not much exposed to this mechanical circulatory support devices, probably that is the area where probably, you need to work upon. Other than that, I think, it went well. Thank you. Thank you very much. Yes, sir, and Himal, for, being part of this program, and, for wonderfully coordinating this session. Thank you so much.
Thank you. Thank you, Dr. Imal.
Thank you, sir. It's a pleasure
Thank you, Dr. Ravi. Pleasure is
having a
mine.
session with
Pleasure
you.
is
Yes.
entirely mine. Thank you,
Yeah.
Dr. Karthik and Dr.
Thank you, thank you,
Ramprasad.
thank you, sir.
All the
Thank
best.
you.
See you soon sometime.
Thank you, sir. Thank you.
Bye bye.
Well,
Thank you, Ravi. Bye.